Good afternoon. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School, and welcome to today's program on Better Together, one of our dialogues, and it's the first one for this calendar year, and it's part of a series of Harvard Medical School programs that have been responsive to Harvard and the Legacy of Slavery report and its continued efforts. Today's program is co-sponsored by Harvard Medical School offices, the Center for the History of Medicine of the Countway Library, the Department of Global Health and Social Medicine, the Center for Bioethics, and the Office for Diversity, Inclusion, and Community Partnership. And thank you for joining us today. Please note that this session is being recorded and live closed captioning is available. In addition, your microphones are muted and the chat is not available. Questions, however, can be posed through the Q&A function on your screen. Following the presentation, which will be for roughly 55 minutes, we will engage in the Q&A so that you can add those questions during the presentation and right after, and we invite you to join in that conversation. And now, turning to today's presentation entitled Better Together, Reflections on Medicine, Racism, and Society, a conversation with Rana Hogarth. A little bit about Dr. Hogarth. She's an associate professor of history at the University of Illinois at Urbana Champaign. Her research focuses on the creation of ideas about racial differences in North America and the Caribbean, as they emerge through the language of medicine and its allied fields. She's the author of Medicalizing Blackness, Making Racial Difference in the Atlantic World from 1780 to 1840, which examines how white physicians defined Blackness as a medically significant marker of difference in slave societies of the American Atlantic. Her work has appeared in Social History of Medicine, American Quarterly, African and Black Diaspora, and International Journal, American Journal of Public Health, History Compass, and in the edited volume, Medicine and Healing in the Age of Slavery. Dr. Hogarth recently contributed an essay on the topic of race in Keywords for Health Humanities, a volume edited by Sarah Altschuler, Priscilla Wald, and Jonathan Metzel. Dr. Hogarth recently also served as a historical consultant for the NEH-funded project Innate, How Science Invented the Myth of Race, a distillations podcast and magazine that launched in February 2023 by the Science History Institute. And now it is my great pleasure to turn the microphone podium over to Dr. Hogarth. Welcome.
Thank you so much, Dr. Reed, for that introduction, and thank you so much for inviting me to share some work. What I'd like to do now, as soon as I can get access to the screen sharing, I would like to offer a presentation. We'll basically cover some of my previous research into race, but also we'll focus on some of the new projects that I have that also tie into the myth of race and its damaging effects. So as soon as I can, I'm going to try my screen sharing. I think I am not able to share it just yet, so I'm going to, there we go, share now. And hopefully everyone can see. Fantastic. Okay, so you can see the title is Racism, Medicine, Society, A Brief History. Brief is obviously in quotations because this is a very long history. I will be taking you through many centuries, so I'll do my best. But brief is also in quotations simply to sort of flag to the audience that this is really not a brief history at all. If we think about how deep racism and the idea of innate differences are and how they've emerged in medicine, we find that this is actually quite a lengthy story. So I will go ahead and give an overview for my audience, because I think it's always a good idea to give you a sense of where I will go and how this will sort of move forward. So what I really want to do today is just provide a historical framework for understanding racism and anti-Blackness in medicine. I'd like to provide a brief overview of how damaging myths about Black people's bodies have permeated medical knowledge production in Western medicine across centuries. I'd also like us to consider how assumptions and subtle references to innate racial differences still linger in clinical settings, medical discourse, and public health messaging. I hope that will be a point that's particularly useful for any of our clinician members of the audience. And finally, I'd like to discuss how these enduring myths, in conjunction with exploitative treatment of Black people in the name of medicine, are illustrative of the ways in which racist thinking is actually built into the system of medical knowledge. So this is not simply past examples of isolated racism or bad actors, but of actually far more bold and perhaps more provocative claim, which is to say that the idea of constructing racial difference, of treating Black people in the way that they have been treated, is actually a feature of the medical landscape and not a bug. So that's sort of the big takeaway claim. So to launch into this, I want to share a little bit from sort of where I come from as a historian. So I'll offer you a quotation. This is from the early 19th century from Dr. Collins, who was a physician and slave owner in the West Indies. And he has this very striking quotation, which I think encapsulates a lot of the ways in which we still think about race even now. And that is to say, he says, quote, "Besides, there are many striking variations between the temperaments of the whites and those of the Negroes, sufficient almost to induce a belief of a different organization, which the knife of the anatomist, however, has never been able to detect," end quote. In making this kind of a statement, Dr. Collins alludes to this idea that there is some kind of difference, right? He talks about temperaments, he talks about some kind of something that maybe is intangible, but also gestures toward the idea that the anatomist, looking for the body, looking for the actual material, tangible things, not quite there yet, but he knows that it's sort of there. And that's kind of what I have seen in looking at race over the course of these centuries, and looking at that even now, how we talk about it, where some folks will say, okay, well, of course there's no biological basis, but yet we still have attempts made to locate some kind of difference, to explain something. And it's as if we just haven't quite detected it yet. People are, well, very much still trying to. So I open with this quotation to give you a sense of how I am orienting this discussion today, and sort of my frame of reference for delving into the topic of race and medicine. Again, another quote, and this one is actually a quotation that I think will really perhaps resonate with folks who have heard of these studies about pain and tolerance for pain, and the idea that Black people allegedly have a higher pain tolerance. This actually was, I think, very well known from a maybe 2016 study at UVA. Well, here is an 18th century reference to that very idea. So this comes to us from Dr. Benjamin Rush, very well-known figure in the history of American medicine. He writes, quote, "A fact from Dr. Moseley of the indifference in which Negroes submit to operations in surgery in the West Indies. Even in this country, the Negroes have been observed to handle fire without an emotion and not suffering from it like white people." So this is one of these very clear statements from Rush, who is an anti-slavery physician, I should add, who is clearly suggesting that Black people have a higher pain tolerance. Now, to be clear, as a historian, I love to show my work, and I'm always indebted to the wonderful folks at Archives. And so these are sort of the notes, Benjamin Rush's notes, where he makes this claim. So it's one thing that you find in, let's say, a publication. It's quite another thing to sort of see the unpublished handwritten notes where he is sort of reflecting on this idea of innate difference. Now, I should say that this idea was not Rush's original idea. He cited another physician, Dr. Benjamin Moseley. And that sort of reference to pain tolerance, this difference in sort of pain tolerance, is here in this treatise on tropical diseases. I show this to you to, one, give you the sense of where the historian is in terms of how they make these connections and how they do their research, but also to kind of give you the sense of a sort of paper trail, a clear paper trail of these very damaging ideas about innate racial difference and where they emerge from. And I think particularly talking about Benjamin Rush as an anti-slavery physician is key, because I think in many ways, when we think about some of the very harmful and damaging ideas about Black people that have emerged in medical discourse, it's very easy to say, okay, well, those are pro-slavery or simply terribly racist physicians from the past. And I think we can also consider how someone who, like Benjamin Rush, who saw himself as an ally to people of color, to African Americans, who very much wanted to see the end of slavery and sort of better circumstances for African Americans, could still hold these kinds of views. This is sort of a jumping off point for me, again, as I sort of navigate this discussion as a historian. This is sort of a jumping off point for me when I was thinking about my first book, my research that really led me into these archives. And that was one to, as I mentioned before, to really impress upon my readers and today the audience that even though we have, slavery very clear and present in the 18th century, that's actually not necessary for this process of medicalizing Blackness and reifying Blackness. And I use that term as a way to sort of signal the ways in which white physicians had been constructing Blackness as this sort of tangible, real, medical, clinical thing. It had clinical value, ways in which they made it seem as if it was an aspect of one's body and biology. And what's really key here is that both pro and anti-slavery physicians engaged in this kind of medicalization of Blackness. Both believed that Black people and white people's bodies were not equal. Both held the view that Black people's bodies were peculiar and in need of explanation. And that's especially important when we think about later research and later publications that I will discuss in this presentation. But the idea that Blackness needs to be explained somehow, that it is something that you have to devote scientific energy and effort into. And that in and of itself is part of this medicalization of Blackness, but is also sort of, I think, emblematic of the ways in which medicine and science have sort of created a landscape that is very fertile for this idea of marginalizing, pathologizing Black people's bodies. And I really want to, again, just impress upon the audience that when I think about the construction of racial differences and the medicalization of Blackness, these are sort of mutually dependent forces. And they are necessary and essential, I believe, to the development of medical knowledge production in the Atlantic world and beyond, which is something that dovetails with my current research project. So, as I said, we'll cover the 18th century, the 19th century, and we'll get into the 20th century as well. So I want to offer some examples. I like giving examples to the audience, also sort of sharing my source space to give them, again, a sense of what I do as a historian, but I enjoy giving examples because it's something that at least the audience can sort of take away from this talk, which is really focusing on pretty weighty and intense issues, something to sort of ponder over. And so the first example I want to offer is that of yellow fever in relation to the ways in which Black people's bodies become medicalized and the idea that Blackness is medicalized. So for those in the audience who don't know, yellow fever is sort of this very intense, scary, hemorrhagic fever. It continues to be something that would evoke fear now. It most certainly did in the 18th century. And it was actually a very common visitor to the Eastern American Atlantic seaboard, very common in the West Indies as well. And what we find is yellow fever was the kind of disease in epidemic proportions that would clear out cities. People would flee. It caused very high death rate. What we have, though, are a lot of observations left behind by physicians who noticed differences in who was getting sick with yellow fever and who was not. And we can clearly see in the historical record this idea of yellow fever attacking its victims along racial lines. So physicians viewed white people and unacclimatized newcomers to the Americas as the most vulnerable to getting yellow fever, while Black people were regarded as naturally immune. And these views lead to erasures of Black people suffering from this disease within the historical record. So I give you, again, another quote, and this is from Dr. John Lining from 1748, where he writes, quote, "There is something very singular in the constitution of the Negroes, which renders them not liable to this fever," end quote. So there is sort of, again, encapsulating with this quotation, this idea that this disease falls along racial lines and that Black people are not going to suffer. And we know now, of course, that one, yellow fever, it's vector-borne, but that's not understanding that people had in the 18th century. But we also know about these erasures in the historical record. When physicians are saying that Black people don't suffer, when physicians are writing about yellow fever and sort of putting Black people to the side as saying, well, we don't have to worry about them. That is sort of the absence of their suffering sort of gives us, you know, that moment of pause to say they're being neglected. Their experiences are being neglected. Thankfully, historians, I'm indebted to so many who have looked into the yellow fever epidemic, have actually started to ask questions about suffering. And what the question I wanted to know when I was researching my book was really about, you know, what was that experience like in terms of physicians saying, aha, this is a racial disease? How do they know? How were they so sure of it? And so looking back at the yellow fever epidemic that strikes Philadelphia in 1793, I was able to uncover some answers. So I've referenced this treatise, and you can see this on the slide. This is from Dr. John Leining, very respected physician. He actually worked in Charleston, South Carolina, and he would have had ample contact with captive Africans, actually directly coming over from Western Africa. What's interesting is that yellow fever was endemic around that region. And so any Black person he might have seen, any captive African person he might have seen, could very well have survived a case of yellow fever, because yellow fever does confer immunity. It's acquired immunity, but it's not racial immunity. So it's likely that perhaps someone like Leining writing about this, making this observation, was actually seeing people of African descent, captive Africans coming in who had maybe already had an experience with yellow fever and survived it. But again, this knowledge wasn't quite clear and wasn't transmitted. So instead, what we have is when yellow fever comes to Philadelphia, we have this sort of very dramatic moment where we have a figure, again, Dr. Benjamin Rush, sort of being asked to take the lead and sort of guide Philadelphia through this very challenging moment. Rush, as I said before, and I alluded to before, was very much opposed to slavery and saw himself as a friend of the Blacks, as he might say. He actually corresponded with Richard Allen, who's pictured here, and a very well-known and prominent free African-American leader of the Free African Society in Philadelphia, so sort of mutual aid society intended to assist African-Americans living in Philadelphia. He and Rush and Allen correspond, and Benjamin Rush essentially, having read John Leining, having read up on all the medical literature, actually writes a letter to Richard Allen to say, will you convince African Americans, members of the African Society, to stay behind and assist during this yellow fever epidemic? And his reasoning is very clearly racial. We know this because it is written down in the letter that he sends to Richard Allen. And so, again, I want to sort of impress upon my audience, this is sort of the work that we do when we go through archives. We read through these kinds of handwritten letters, we read through treatises, and we kind of try to understand and piece together what was going on in that moment. But here is also something that's quite significant, and that is a very clear, like explicit statement that Rush's understanding is that this is a racial disease. It affects particularly one specific race. And he's basically pleading with Richard Allen to help, right, as the sort of the leader of the African Americans in Philadelphia. So the excerpt that I have here from the letter is, quote, "It has pleased God to visit the city with a malignant and contagious fever, which infects white people of all ranks, but passes by persons of your color," end quote. And that's sort of the key moment where he's basically saying this disease is not going to impact African Americans. And he asks Richard Allen to convince other African Americans to stay behind, which they do. They absolutely stay behind. They are trained in nursing the sick, in bloodletting, in all of sort of the standard practice at the time. But of course, as we know now, and as actually Rush would come to realize, Black people are not innately immune to yellow fever at all. In fact, Richard Allen contracted yellow fever. He did survive, but Rush was aware of this and actually publicly backtracked on his claim about Black people being innately immune. That said, the backtracking, of course, had a caveat. And this is sort of where I have here sort of the idea of racializing suffering. In Rush's 1796 account of the bilious-remitting yellow fever, he actually disavowed the idea of Black immunity, but said, he says that the disease, quote, was lighter in them than in the white people. I met with no case of hemorrhage in a Black patient, end quote. So we have here, again, Benjamin Rush, a very respected figure, sort of seen as a leader during this great calamity in Philadelphia. He sees himself as an ally of African Americans, so they sort of clearly see him as a credible person. So they stay behind, they assist, and yet here they are succumbing to yellow fever. While Rush is willing to admit his mistake, he is not willing to say that Black people suffer in the same way as whites. In fact, he suggests that they don't suffer as much. And I think when he says something as dramatic as I met with no case of hemorrhage in a Black patient, it's sort of a way of saying the worst of the disease does not affect them. So, thinking about this as a historian, it's one thing to get the words of a respected white physician who had the luxury to write many of his observations down. It's really perhaps one of the greatest joys to get the written word of African Americans in this time period to give their perspective. And so what you see here on the screen is actually a short excerpt from a pamphlet that's penned by Richard Allen and Absalom Jones, another African-American leader in Philadelphia. And it's quite interesting to see African-Americans actually push back on the kinds of myth-making about their bodies and push back on the idea that they do not suffer. This is perhaps, again, in writing this book, reading that passage, it still for me is one of those moments of, it stands out. It's something that I think will stay with me forever because it is this moment where African Americans are so forcefully pushing back and challenging what is supposedly received medical knowledge. So what they write is, quote, it is even to this day generally received opinion in this city that our color was not so liable to the sickness as the whites. We hope our friends will pardon us for setting this matter in its true state. The public were informed that in the West Indies and other places where this terrible malady had been, it was observed the Blacks were not affected with it. Happy would it have been for you, and much more so for us, if this observation had been verified by our experience. So here is a case of two African-American men writing a pamphlet, printed pamphlet, stating, we suffered. And this is sort of where it comes from, the excerpt. They said, during that yellow fever epidemic in Philadelphia, many kinds of narratives emerged about African Americans. While they're there helping, staying behind, there are, of course, very damaging rumors that are spread about African Americans, i.e. that they are stealing, they're looting from the families they're supposedly helping. Basically, a smear campaign for an already marginalized group that is putting their lives on the line during an epidemic. So Richard Allen and Absalom Jones sit down and sort of try to set the record straight. And in doing so, they offer, I think, a very crystal clear example of Black people pushing back against these damaging statements and leaving that in the historical record and basically saying, indeed, we did suffer. I mention this because this episode in Philadelphia, as I said, there's such a paper trail. It's so very clear and very easy to find in the historical record. And it tells us a lot about how people were thinking about race and racial differences. It tells us a lot about medical authority. We think about Benjamin Rush. It tells us a lot about the mindset that even somebody who saw themselves as doing good, somebody like Benjamin Rush, was still very much participating in what would become a sort of longstanding harmful myths about Black people. So I'm going to, as I said, it's a brief history. I'm going to kind of push us forward into the antebellum period. And basically, I do this because I want to kind of give you a sense of how enduring ideas about innate racial difference are, like how long this has continued, how long we can sort of trace this in the historical record. But I also do want to share a little bit about sort of exploitation and other ways that suffering emerges in the historical record. If we think about the 19th century medical landscape in the United States, we may turn our gaze to the antebellum South, although with wonderful new work that's just been published, a small plug for my friend Chris Willoughby, whose first book is out, Masters of Health, where he looks at Northern medical education and ways in which pernicious ideas about innate racial difference and anti-Blackness were spread in Northern medical schools and medical education. You know, I'm going to focus our attention on the South, simply because, you know, again, there's a very robust paper trail. If we think about ways in which Black people's bodies were exploited, neglected, and ways in which ideas about innate racial difference kind of proliferated. So it should come as no surprise, I'm sure, to anyone in the audience that medical schools, mostly in the South, but of course some in the North, preyed upon the bodies of free Black people and enslaved Black people. What we find is that Black people were, to borrow from the wonderful Todd Savitt, were invisible and visible. They are visible, obviously, due to their skin color. They're invisible legally, and as in they don't have legal recourse to stop the predation of their bodies. So grave robbing, very common in African-American cemeteries. Cemeteries are indeed segregated. If we think about the use of bodies for anatomical demonstration, for clinical instruction, disproportionately in the South, we're seeing a lot of African-American bodies used in this way. And because of this, medical schools in the South capitalized on the sort of the social landscape, the inequities, and basically what slavery offered in the sense of access to bodies. So Southern medical schools didn't really hide the fact that they were using Black people's bodies to advance medical education, and in fact to advance the reputation of their medical schools. So I'm going to use the Medical College of South Carolina as an example, simply because it builds itself as the oldest continuously operating medical school in the Deep South. So it's founded, I believe, 1824, 1826. And essentially, one of the great claims for that medical school was, this is actually in, I believe, faculty meeting notes in the 19th century, was that we're going to be able to compete with these older, more established institutions in the North and in Europe, because we can just get bodies from the, quote, so-called colored population. What you actually find also is that Southern physicians are able to make claims of, now we can actually focus and study the different ailments that impact the so-called the African race. So we actually see this exploitation, but also a way to reify ideas that there are innate racial differences. So as I like to sort of term it, the way of sort of the looking at Southern medical education, the very construction of racial difference became a core component of the growth of Southern medical education and medical infrastructure. And I want to just put this caveat here, because everybody, you know, asks this. They're like, wait a minute, if they think that Black and white people bodies are different, why are they using them for teaching students? Why are they using them for anatomical demonstration? And so I would say that despite believing that Black and white people were physiologically different, white physicians in the South still relied on their bodies as clinical teaching material, because I think that those bodies were sort of good enough. They were bodies to practice on. They were bodies that were similar enough, but they lacked the sort of delicateness, if you will, delicateness in accordance to sort of how they would view white bodies. So a really great example of how this might work would be looking at Deirdre Cooper Owens's work on the establishment of gynecology in the United States. The fact that you have physicians who are preying upon and in many ways abusing Black women, enslaved women, using their bodies for surgeries, repeated surgeries with no anesthesia, and then going to take that knowledge and then apply it to white women, but with anesthesia, and I should say wealthy and well-to-do white women, ladies, if you like. There's this idea that they've practiced on and gained the knowledge and perfected their techniques on these Black women's bodies. So that's sort of a clear example of how we see Southern practitioners saying, okay, we're still going to use these bodies even though we think they are different. Now, I mentioned this as sort of the antebellum era, and in some cases, many folks can say, well, those are the Southern physicians, perhaps it's in their best interest or it's political as to why they might hold this view. They're very much protective of their Southern way of life, of protecting slavery, but the reality is actually much more grim, and that is that this was sort of a universal belief that you would find even in the North especially amongst the union. And I say this sort of segue into some of the material that I found in working on my second project, which directly goes to the point of believing in innate biological differences between Black and white people. And this is actually something, if you see on the screen, that's U.S. Sanitary Commission, i.e. the union. During the Civil War, there was actually a so-called Negro questionnaire that was sent out to medical officers with the idea of collecting scientific data on differences between Black and white troops. So you can see in sort of the highlighted portion of the document here, so this would have been 1865, the U.S. Sanitary Commission is instituting inquiries in a scientific point of view as to the physiological status of the Negro as compared with white soldiers. So the idea is to collect hard evidence, data, that would show some of these alleged innate differences. And this is an effort that is spearheaded by the Union during the Civil War to end slavery. So I offer this again to sort of draw our attention to the way in which ideas about innate racial differences are essentially, they're so widespread. To say that it's confined to a specific region, I think is kind of not quite the case at all. I show you this other image here from that so-called Negro questionnaire, where you start to see questions about the effects of amalgamation, i.e. racial mixture, on the vital endurance and vigor of the offspring. So this is in, again, 1865. I highlight this particular point on the survey simply because if we start to think about scientific interest in studying mixed race people, in studying so-called race traits, we can see ourselves going into the realm of eugenics, particularly where we think about fit races, racial traits, heritability of certain kinds of traits. And in many ways, when we talk about eugenics, there has not always been the impulse to go back to slavery or to even go back to the question of anti-Blackness. And that's sort of what I've decided to do in conducting my current research. And so in finding something like this from 1865 and finding this sort of question about amalgamation, about the idea of the endurance and vigor, vitality of offspring, it actually resonates very much with studies that were conducted later in the 20th century. So for example, this study here, which is Investigations of the Military and Anthropological Statistics of American Soldiers, contains what some might say a clearinghouse of data of like sort of anthropometric and anthropological measurements of Black and white troops that in later decades would be used by eugenicists who were interested in studying different race traits and racial mixture. And again, you will see here that this is an effort by the Union. It's actually something spearheaded by Benjamin A. Gould, who was actually not a physician, but was very much interested in this topic of innate racial differences. He, as nobody will be surprised, he believed that Black and white people were innately physiologically different, and he had a very negative opinion of racial mixing. I should also say, since I am, giving a talk to probably a figure well known to the Harvard community, Willoughby Agassiz, he also was quite interested in the matters of race, but also in matters of race crossing. And this is, again, a concern that's emerging in the 1860s. So this is sort of a quote from Agassiz that I think, again, encapsulates his concerns about race crossing. He says, quote, "As soon as these sexual desires are awakening in the young men of the South, they find it easy to gratify themselves by the readiness with which they are met with colored or mulatto house servants. This contact blunts their better instincts in that direction and leads him gradually to seek more spicy partners, as I have heard the full Blacks called by fast young men," end quote. So we have figures like Willoughby Agassiz, well-known polygenicist, but also respected in scientific circles. We have the U.S. Sanitary Commission collecting data on race traits and amalgamation or race crossing. These are all concerned with what these figures are all concerned with vitality, vigor, but also the degeneration of race and sort of the degeneration of white American civilization. A figure who gives this his full attention is actually Charles B. Davenport. He's probably perhaps well known as a eugenicist. And as I said before, eugenics is not necessarily always associated with the slavery era or always associated with studies of racial fitness. But as I have found in doing research for this current project, it turns out there are much, much closer connections between early 20th century eugenics and slavery than we thought. So Charles Davenport, a leading American eugenicist, actually conducted race-crossing studies. He conducted race-crossing studies focusing on Black and white so-called racial hybrids, so mixed race people. And again, he looked to data from the Civil War for the process, the methodology. He at some point cites Benjamin Gould. He is very much interested in how to collect, study, and measure and quantify racial traits, because there is a belief that there are so-called Black traits and white traits, and what will happen to the offspring of unions between Blacks and whites. What traits will they have? And this goes from checking into their vitality, their vigor, but also to their physical appearance and skin color. Now, I would like to add that Davenport and white eugenicists were not the only people who are interested in these kinds of questions. I have on here Carolyn Bondé, who did her own study on mixed race families of high achievement. I should say that her work is very different from what eugenicists were trying to do. Essentially, Carolyn Bondé refutes many of some of the claims that we might find from figures like Charles Davenport. What she does is she goes and sort of using her training in anthropology to sort of think about ways in which mixed race people have made great contributions to American society. And she actually talks about ways in which, that measuring the same way that eugenicists do to kind of basically show that there is no degeneration. And so she also trains at Harvard under Ernest Houghton. And so she publishes her master's thesis, a study of some Negro white families. And I should say I've been very lucky to have the chance to look at some of her papers at the Peabody Museum archives. And so again, kind of looking at ways in which we have scientists, anthropologists, eugenicists, biologists, actually measuring different bodies, Black, white, and mixed race. And as I said before, Davenport, who is really a leader in the American eugenics movement, actually looks back to the Civil War, looks back to how we ought to be measuring people, how we ought to quantify race and race traits. And again, the underlying assumption is that there is an innate difference and that we are going to find it. We think back to that quote that I gave you where the anatomist has yet to detect it. Davenport, eugenicists, are trying to detect it. People like Benjamin Gould in the Civil War studies were trying to detect it. And so it's this constant quest to try and detect this proof of this innate racial difference, which we can all say, oh no, that it doesn't exist. But this is sort of, and what I'm trying to share with you today is sort of this very long history of this kind of research, energy and effort into looking for and ferreting out tangible proof, objective proof, if you will, of innate racial difference. And I should say that it's not just the vitality, it's also in terms of predicting what mixed race people will look like, how we can discern and detect and quantify degrees of racial features on mixed race people's bodies. So as you can see on this particular slide, these are actual hair samples that were collected by the Eugenics Records Office, which was founded by Davenport in 1911. Those are actual hair samples from a mixed race family. I've blanked out their names because it does list the family's last name. I think it's very sensitive material. And so I think it's rather unnecessary to name the family. But I do think it's important to consider the ways in which the attention to measuring and quantifying race and understanding race and making race real often, depended upon the curl of someone's hair. So from my understanding, these samples were voluntarily sent to the Eugenics Records Office. They were sent from a mixed race family that resided in the island of Jamaica. And it turns out that Charles Davenport actually conducted his race crossing studies in Jamaica. He found that it was easier to gain access to mixed race people for a number of reasons, which I'm happy to discuss in the Q&A. But I wanted to sort of share this with you because it kind of boils down to this attempt to try and show and capture racial difference. If we think back to yellow fever, the idea was, okay, well, you can't see the difference, but the difference is there based on susceptibility to the disease. But that turns out to not be true. There is the idea of, okay, we can, clearly see this difference if we measure and we look for it. And this, again, is not true. Then there's the idea, well, we can just read this upon the body and we can see traces of Black traits, which is essentially what Charles Davenport was looking for, if we're just careful and attentive enough. And so I show you here, these are the results of Davenport's studies on the heredity of skin color, where he actually pays attention to the curl of hair, as I had mentioned before, and sort of the expectations of what mixed race people ought to look like. So you can see also in the text that he relies on this very outdated language in describing mixed race people. A quadroon daughter by a white man had an octoroon daughter, has curly hair, but not at all kinky hair. This is, again, that reference to trying to sort of clearly demarcate Blackness. Where might the Blackness be? Well, it's curly, but it's not quite kinky. If we look further down, there's yet another description of a son with fair skin, black wavy hair, a daughter with dark olive skin and straight black hair, a son with swarthy complexion, but deeply tanned skin, with much yellow, dark brown eyes and thick black hair, which shows a trace of a tendency to curl. So it is, again, trying to pin down a racial trait on a part of the body, on hair. And in these studies that Davenport conducts, as I said, he's inspired by much of what transpires during the Civil War and that data collection effort. But he's also interested in using any tools at his disposal to quantify skin color in ways that I think Gould and the Civil War era medical officers could not have imagined. So, for example, Davenport uses a color wheel, which is used to teach children color blending. It's a color wheel that he sort of repurposes from Milton Bradley and puts, different kinds of colored paper, so that if you spin the wheel and the colors blend, that would be something given to his field workers to then go and apply to the skin of mixed race people. As in, they would be asked to roll up their sleeves to get sort of their upper shoulder, arm area, and then you would have a trained field worker simply take down percentages, what percentage of yellow, of red, of black, of white that they would note in skin. I should say that while this may sound very strange and terribly imprecise to us, in some ways this is actually more precision if we consider the ways in which census takers were supposed to tell the difference between somebody who was octoroon or quadroon in the 1890 census. It was just eyeballing it. So Davenport thought that he was actually doing something that involved a kind of scientific rigor. So I share these information with you just to sort of give you a sense of this long history of sort of trying to see, reify, and make Blackness a part of one's biology. And I do this even though we know that race is a social construction and it's not a biological fact, and we hear this all the time, it's a social contract, it's a social contract. What I've actually seen is that the body is really the site of where the construction is. And because we negotiate the world and we pay attention to bodies, and because physicians in particular, clinicians, those in healthcare professions are dealing with different bodies, that the body is very much important for understanding this development of race and why race continues to linger in the way that it does. So I always say that, yes, it is a social construction, but it's a social construction that we're supposed to believe we can just see it on the body, and that it's something that is just simply obvious to us. And that is that creates a kind of this tension, I think, that in many ways is manifested in our discussions about racial disparities, about racism in medicine, about people being treated differently and not having their pain taken seriously, of saying, well, making broad generalizations about one racial group is more prone to X, rather than thinking about the ways in which it's racism that impacts the way that that body navigates space and the way that that body receives care, and how that body may or may not be able to thrive in a given society. So this clearly still has resonance for us today. And I offer some fairly recent articles here that kind of, to me, speak to the way clinicians and others have sort of been interested in this kind of history and sort of thought about the ways in which race makes mischief in the clinical setting. So it's really one of those moments where, for historians, it's nice to see that physicians and clinicians are interested in sort of talking to historians and thinking about the ways in which race correction, the ways in which taking race to mean something more than it does, is actually not helpful. So there's sort of one of these really important pieces about race correction, particularly in clinical algorithms. I'm sure that folks in the audience are certainly no strangers to the case of the EGFR, which was used, I guess it's fading out, but is used for understanding kidney function, which has race correction built into it. And that for people who are Black, so it's Black and non-Black. If you're Black, then you get points added to that value, which can cause mischief in terms of giving people, particularly Black people, a sense that their kidney function is higher than it is. We also know that there are racial algorithms involved in clinical decision-making around VBAC, which is also here for obstetrics. There's a really interesting point that is brought up, and I want to just share this as my last slides, that's brought up by this wonderful article, again in the New England Journal of Medicine, where it looks at the issue of EGFR, but it raises this really interesting question. So I mentioned that there is race correction built into it. If you're Black or non-Black, and if you're Black, you have these points added, value added. What do we do in the case of somebody who is biracial? Where if there's a patient who has one Black parent and one white parent, and they identify as Black in one setting or white in another setting, and sort of, well, which value is which? And what if there's a moment in which that patient can't really say what their designation is? Then the clinician has to make sort of the guess. And it sort of gives you, I think, a really nice example of how what seems to be something that should be precise is actually not precise, because it's based on this idea of race, which is not precise and isn't doing the kind of work that we want it to do. So I offer this as an example, a fairly recent example. I believe these are articles that were most certainly published, I think, during the pandemic, maybe in 2021 or 2022. But they're sort of recent examples of the ways in which clinicians and others have been sitting down to say, we do actually have to think about the ways in which race, the concept of race, and the assumptions about innate racial difference are actually hindering clinical practice and not doing the work we want it to. So I wanted to sort of offer these examples as a way to sort of bring us to the current moment, from starting from the 18th century, bring us to the current moment to give you a sense of how this long enduring idea of innate racial differences has lingered. And it matters very much so even now. So starting in the 18th century and mentioning that discussion about differences in pain tolerance, the article that I also referenced about a survey done at UVA, that was 2016, where you had residents suggesting that Black people had thicker skin than white people, or that Black people's blood coagulated more quickly than white people's blood. These kinds of medical myths do still exist. And I think the real challenge is to understand how to sort of find them or find their origin points and sort of stop their propagation. How something that somebody might have heard but then never gets corrected, a sort of myth making, if you will. And so I will go ahead and just give us some time for question. I will go ahead and just end there, but I want to thank you all for your time and thank you for the opportunity to share some of my research and insights.
Thank you very much. Thank you for a really provocative presentation that brings up some history that I've known, but new history. And for me, it's very interesting the ways in which we continue to learn more, where we think we know how we got to where we are today. And when you start to uncover and you start to peel back, you begin to recognize the ways in which we practice, we think, are so much embedded in what came before. And so as we think about this, and you gave this more recent example of GFR, you talk about the Virginia study and what the pain and how the medical students and residents consider pain, and it's sort of baked into the society is how I think about part of that. For many, they think of race as biological difference. And can you talk a little bit more about how some of this is built into our medical or scientific institutions in terms of how we produce knowledge or policy, how these beliefs about this biological component of race actually has its influence in other spaces?
Yeah, so thank you so much for the question. And again, I'm just so happy to share this part of my research with everyone. I'm really looking forward to as we get into more Q&A. But I really find that, even down to collecting data, to filling out a form, it's always the question when someone says, okay, this racial, if we say Black women have a higher rate of X and Hispanic people have a higher rate of X, what then do you do if you have somebody who is from the Dominican Republic who was Black? like how do we think about the categories that we just hold to be, that we don't really question? You just fill it out on your intake form, even when people are collecting data for research that is published in peer-reviewed journals, where you just have like sort of uncritically, they might say Latino and then they might say Black, they might say, or Latinx and Black, they might make a broad statement, but it's sort of like, okay, what are you trying to capture there? Because that leaves questions. Black is, that can mean so many things. That can mean, okay, so Afro-Caribbean, somebody of ancestry that is maybe Black and Indigenous. It could be somebody who is Black but lives in France or elsewhere. Like, what does that mean when we just simply say the word Black? And I think that there's an expectation that we've been so accustomed to, is that, well, I can see that you're Black, it's on your body, and that's obvious, and that must mean something for your health, and I'm just going to record that as a sort of part of your vital intake information. And that was sort of my point about how that's something that I think we think it's common sense, but it really isn't. And so, yeah, I see this a lot when looking at news headlines, for example. We know we have a problem with Black maternal mortality. And the problem is racism and dismissing Black women's concerns. It is access to care. It is shutting down and closing any kind of clinics and facilities that offer prenatal care in neighborhoods where you have like predominantly African-American or Latinx populations. But when we simply say, okay, well, there's Black maternal mortality, I'm like, I want to see the bigger discussion about the racism and the other policy obstacles that create this. Because I think in a lot of ways, people will look at a headline very quickly from the New York Times and say, oh, Black women have a higher rate of this. And all sorts of things can fill in the gap as to why Black women have that. It could be biology, it could be whatever. And I really want us to be more precise in how we think about this. So I give those examples as just something you come across when you read the newspaper, or something when you come across when you read a medical journal, or when you yourself fill out your form, a medical intake form, how race is doing that kind of work that I think is actually not quite as helpful as we think it is.
So being more explicit about and transparent about what is the question you're asking.
Yes.
And
yes.
With that, as you talk about the researcher, the author, the whoever is doing it, being more explicit there. I think inherent in what you're saying is the person who's checking that box and filling out the form having some sort of idea of what they're even filling out.
Right.
So there's multiple levels of uncertainty in whatever is being put put forth. There is a question in the Q&A, and I urge those who are in this session to please add your questions and comments to the Q&A. The question is, what were the record-keeping practices like in the 19th century for using bodies in research?
Oh, okay. Well, that's a fantastic question. So I could not tell you for, let's say, like sort of the earlier part of the 19th century. You know, if you read a medical journal article, for example, like sort of from the South, any kind of like those, you will see these medical journal articles, and you're not going to see sort of necessarily the same sort of tables and statistics that we're perhaps used to. What I find often are case studies where you will have a physician talking about, you know, visited such and such patient, or I have, you know, 6 or 7 case studies. And that's where their observation is, and they come to a conclusion like towards the end. So where you might have a methods section when we think about something more modern or contemporary, in looking at sort of those medical journals from the 19th century, from the earlier part, I'm not seeing as much statistics as we might see in a medical journal now. That I say that though to say that there is an obsession with statistics in the 19th century. There's growing data collections concern. So this is the time of intense interest in collecting statistics, and reading statistics and sort of making decisions based on that. So the best evidence that I have that's sort of related to my own work would be from the Civil War and sort of that data collection effort. So the Union, and again, from my early beginnings digging through a lot of the Sanitary Commission records, which are at the New York Public Library, we see these intake forms. So there are these fabricated forms that will list, you know, the kind of specific data. So they have the one that's based on your, where are you from? They ask those kinds of questions. They will ask, you know, what race were your parents? They'll ask about your level of education. And so some of these forms are, you know, which is putting in a number, height, weight, etc. Some of them involve the officer having to write out sentences. So there's sort of the clear, quick data collection of like a number measurement versus them sort of handwriting something out. That's for one aspect of the data collection effort by the U.S. Sanitary Commission. Then there are other forms that are, again, pre-populated, where it is simply just the measuring of the body parts. So they are looking at, you know, like nostril length, arm length, femur length, like all of those things are being collected and compiled. So I know that Gould had others do that kind of analysis for him to give him like the mean, the weights, the averages. So in terms of like what that record keeping is like, I haven't sort of compared that effort from the Civil War that I have looked at specifically to sort of what standards are. I know that the data is not particularly tidy. So for example, they are not taking into consideration the fact that many of the men of African descent are coming in as formerly enslaved, so that their health and stature and all these other things that they're recording as being in poor form are likely due to external factors, clearly environmental, so we say social determinants, but that data is not necessarily being registered, at least in terms of the final tally of the numbers. So yes, they are, in the 19th century, we are seeing a clear attention to and rise in data collection in relying on statistics to make decisions. But in terms of how perfectly organized the Gould, the Civil War data set is, I'm still sort of digging through that. And then it would be interesting to see sort of what exactly they're missing, what points they, you know, didn't know how to explain, because it is quite a lengthy, very lengthy study. And I should add, that's just one. There's another one by the Provost Marshal General's office that also has collection of data on various traits and sort of physical traits of the men. So it's a great question. And I understand definitely where the question comes from because of the 19th century and sort of the rise of statistics. So thank you.
But as you say this, I have is there anything that documents why certain characteristics, traits, items were collected? In other words, why would someone collect nostril length? Is there a theory behind any of this, or is any of that offered?
So I can speak more generally for example, for collecting data on feet. the assumption was that Black men just had flat feet. And this has been, you can actually find that in older references from the 18th century, like in talking about the stature and shape of Black people. In some ways, I think that for the Civil War data collection effort, at least around the idea of like, well, Black men are prone to flat feet, or we are expecting to see it, it confirms something that had already been lingering in sort of the historical medical ether. So in the same way, thinking about tuberculosis, respiratory complaints, the idea that African Americans suffered from respiratory complaints, tuberculosis, is something that's quite common during the era of slavery. Claim that tuberculosis and poor lungs, weakened lungs, was an expectation. That same data is then looked for in the Civil War data collection effort. And what you'll actually find is Union medical officers saying things like, oh, it's well known that these people are prone to respiratory ailments, and this data bears it out. So I feel like in many ways they're asking for or looking for things they want to confirm. But that it's
very much confirmatory. It's like we want to say X, so let's go look for data that will give us X.
And that's precisely what they do.
Okay. All right. Very good. There's a question. How does understanding the history of medicine and scientific knowledge production help us understand contemporary issues in healthcare?
Yeah, like so again, in thinking about this question, it's sort of me wanting to, as a historian, I really want to be able to reach other audiences, clinicians, healthcare practitioners, community activists. I want to find a way to make sure when we talk about health disparities, when we talk about racism in medicine, we are fully aware of this as not a new phenomenon or not a case of bad historical actors, that this is actually very much a part of the development of medical knowledge and practice in the West. I want this to sort of be well understood that when, somebody has the sense of, I have been to a emergency room and I feel like I have been dismissed, or people will say, oh, you're fine, or you're just seeking pain medication, or I want in a way to use what I do as a historian to sort of translate that to say, you're not making it up. You are not losing your mind. This is completely, it tracks with what we know historically, that Black people's bodies have been dismissed, have been pathologized, have been treated as other consistently. And so in doing this kind of work, I want to say, let's think about where people got data. Let's think about the questions people posed in collecting data that was supposedly objective. I want us to think about the ways in which much of this is based on a hostile view towards the Black body. And that is something that I think we shouldn't ignore or say, oh, well, that happened in the 18th century, so, we've learned so much. Like, I'm kind of not a big fan of the progress narrative, simply because, we can still see the lingering effects of some of this damaging historical thought. And I think to that point of the UVA study, I have to say, in 2016, I had, really well-meaning friends say, can you believe it? And I said, yes, I can. Mm-hmm. That's what I've seen. And I would like that kind of a way to sort of translate that knowledge to folks who are in the medical profession or folks who are doing healthcare work, to kind of think about, okay, if this is how the system is built, if this is how the system has been oriented towards looking at specific bodies, how do we sort of dismantle that, rather than saying, okay, that was just one racist person a long time ago.
So just a piece with this, because one of the things that struck me when that study came out in 2016 was the extent to which we talk about it. And in this conversation, we're talking about how some of this is embedded in the fabric of medicine and research. But it's also translated into the fabric of our country. So what's been built up as the myths within medicine is also built into the community dialogue, and people think about these kinds of issues. Can you speak to some of this? Because it doesn't just stay in the operating room or the clinic room.
Right. And I think that's part of really the big challenge, because it's so diffuse. It's more than we think. It's not just, okay, you walk into a hospital, or there's a notoriously bad clinical practice somewhere. Some of these ideas are, they pulled, residents, it's sort of, how do they get those ideas? Some people actually show up with kind of, well, I've heard this before and I didn't bother to question it. Or, people even saying things that are not true or embedded in like a something that has been misrepresented, or there's a kernel of truth, or it becomes like a rumor that, so for example, there are still folks that might say, well, sickle cell is the disease for Black people. That's our disease. We have to focus on that. And it's like, okay, sickle cell is an inherited disorder that, yes, in the United States, you will see this more in folks that will identify as African American, but the disease itself is going to impact people from the Indian subcontinent, from the Mediterranean, from other parts of the world. And that is something that even someone trying to advocate for sickle cell, and I'm like, yes, we should. And I do think that, especially given how structural racism works and continues to exist in this country, yes, we need to make sure that our marginalized and vulnerable populations are tended to. If that means focusing on African Americans, that's fine, but the disease itself is not this racial thing. And that's sort of where, that comes from an observation that is not completely ungrounded, right? I think it's 72 that Nixon declares like sort of the Sickle Cell Anemia Act, and there's attention for African Americans, and we know that there's lots of good work in Black activists saying, okay, we have to look after our health and put our health in our own hands, which is great. That's what we need to be doing, but we have to be careful with that kind of language, and that sort of filters out beyond just the clinical practice that is,
and the myths that get built out with that. There is a question from the Q&A that goes right along with this. How do you combat medical racism today and educate doctors? And I'm going to say not just doctors, it could be any of the health professions who may have these beliefs.
I mean, that's a great question. I wish I had the one answer for that. I mean, one thing that I will say is that what led me down this path was asking a lot of questions and allowing things that were unquestioned, like things that had been untroubled, to sort of like prod and poke them and say, wait, why did we just assume that? So, in thinking about how we combat medical racism today, there's multiple ways to address this, right? We have policy level that we have to address. We have the day-to-day interactions, ways that we can address this, where it has to do with like asking the question of why have we not bothered to question something we've been doing for so long, or why have we allowed, let's say, I guess a physician who's maybe teaching another generation of physicians to just keep saying things, and no one has stopped to say, that's not true, that's not correct, you're actually spreading something that's not helpful. Obviously, it's going to be very hard for a hierarchical system for someone to say, if I say anything, what if I'm retaliated against? What if I don't get good letters? That's what I mean when I say there's like a policy component to this too. And that's just the example of the medical setting. If we're talking about this in sort of broader funding, in terms of communities, in terms of how our neighborhoods are laid out, in terms of which physicians and which healthcare services are available, that's a whole nother level of sort of like policy level decisions. So in terms of combating medical racism today, it's a lot to sort of think about in just one question. I will say this though, and I hope that this kind of will resonate. I think the work that I do and the work of other really well-known historians of medicine who have looked into health disparities and race have actually advocated for taking a historical view to this. So I'm thinking of the work of Evelyn Hammonds and Susan Reverby, who have been really championing this idea of saying, okay, we need to look at the history of health disparities, which includes looking at segregation. We have to look at, it's not just, okay, here was something bad that happened in the past. This is like looking at it sort of structurally, examining these structures. So I'm sorry I don't have like a quick answer for this very important question. But I think it's a multi-pronged approach that I think historians have something to weigh in on as well, in a way that can help both policy and clinical decision making.
If you think about policy, if you think about the politics of it all, they're intertwined. It's not that you can look in one space by itself. I have a slightly different question within this, and it's around the term racism.
Mm-hmm.
And can you describe for us what you mean by the term racism? Where is it coming from, and what do people mean when they use that term?
Okay, so for racism, and I guess I suppose I'm using this term in, I guess, the way that we use it in everyday parlance, which is sort of to suggest this idea of sort of maligning a group based on their race, a marginalized group, historically marginalized group, and sort of thinking about the ways in which that takes place in all sorts of walks of life. So I'm focusing on medicine, sort of how this racism emerges in medicine. I want to be clear, and I should be clear, that in the 18th century, because this is sort of one of the, it is less helpful, and I typically do not say this, but it's less helpful to say someone like, oh, well, Benjamin Rush was racist. I'm like, what does that mean? It was the 18th century. He was a white male physician. He held views that, of course, we would now say, yes, that's racist. Perhaps a better way to think about it is someone like Benjamin Rush and some of these historical actors from the 18th century, let's say, very clearly treated people who did not fit their ideal, so who were not white and male and educated, as different and inferior. And what I am looking at is ways in which the way that they treated people was sort of based in medicine, that they used as proof, is that these bodies are inferior, or that there's something wrong with these bodies. So to ask a question, there's a great piece by Benjamin Rush that sort of exemplifies this. Benjamin Rush thought that Black people's skin, he postulated that Black people's skin was Black because it might be a form of leprosy. We would look at that and say, okay, that is racist. You are pathologizing Black skin. You were saying there's something wrong with it and it could be cured and treated. The problem, because he felt that that's why Black people have so much prejudice. He's like, if there was a way to cure it, if there was only a way to cure that and get rid of Blackness, we wouldn't have this problem. Notice how he's not critiquing the white response to the Black body. He's not saying we hold these prejudices. He knows the prejudices are there. He wants to find a way to get rid of the cause of it, which he sees on the Black body. So that's where I would say, okay, this is a way in which you are you're sort of pathologizing and further marginalizing this group. This is during the era of slavery. But I would not, to say, oh, well, he's a racist physician and isn't this terrible? That isn't really doing the work. That's not something that I think is particularly useful in this regard. So that's kind of a way in which I think about those figures in the past, which we can now say would be racist, right?
So being able to name it from how we understand things today, but also understand the context and the time.
Yes.
Is critically important. And partly what led to that was the next question that came in. When the two Black scientists refuted the claim that Black people did not suffer from yellow fever, what was the response of the white medical establishment?
So this is a great question. So this is Richard Allen and Absalom Jones. So I should say two things just in terms of answering. So they are both men of the cloth. They're the clergy. They are really responding to, one, not only the sort of erroneous belief from Benjamin Rush, but they are directly responding to sort of nasty pamphlets that had been published by white publishers. I think Matthew Carey is one in particular, that went around and said essentially that Black people were taking advantage of white people. They're taking advantage of white people. They're taking advantage of their vulnerability at this time. When they published their refutation, so their piece where they said, one, we do get yellow fever, we do suffer. People like Benjamin Rush, as I said before, were willing to admit publicly that yes, they do get yellow fever. In terms of other scientific response, like in terms of another physician directly responding to them, I didn't necessarily see a direct response saying, okay, but you're wrong, because you don't suffer as much. Like, I did not see that in terms of the kinds of research that I was doing. Instead, what I saw was a willingness in the medical discourse to say, okay, you do get the disease, but you're still not suffering as badly. So what they're doing, I should be clear, what Richard Allen and Absalom Jones are trying to do is to, one, make it clear that Black people suffer from this disease in the historical record. Two, push back against this claim that they are that physicians know what's best for them, because they're on the ground as observers. So some of these people that are making these theoretical claims, they're not there. So it's kind of like, in some ways, they're pushing back with empirical observation, data driven, not there, like we were there, we know. So anybody who makes a theory about it actually doesn't know. But I did not see like a medical rejoinder, like to say, oh, we don't trust you, or you're not correct in making the claims that you are.
As you give that response, part of it for me, as we look today around issues of representation, as we look today around issues of who is conducting the science, who's asking the questions, who's doing the research, it points to me to this importance of having a presence, so that you are there to refute in a scientific way, to ask, to challenge. And if not there, that challenge may or may not occur.
That's a really great question. And I do think representation in this case definitely matters, because when we look at the historical record, especially from this period, you do not find a lot of written sources by African Americans, and ones that are so accurate in their data collection. So going back to that point about statistics, we know from looking at the burying of the dead, of their records, and then matching that with hospital data, the makeshift hospital data, that Richard Allen and Absalom Jones were very much on point with their data collection. Like they were saying, this many Black people died, these are the houses we went to, this is what the costs of for burial. Their numbers, their data actually is very much, you can corroborate some of that with what we see left behind. So in many ways, their source is, again, it's representation. It is, I'm not going to use the word accurate, but I'm going to say it accords with, or it corroborates with other kind of data. And it is that key piece of evidence that shows us that, here is our proof of Black suffering. And here is a proof of Black people not being passive and sort of having to have this done to them, of them sort of being actively engaged in these kinds of debates and caring about their well-being and their community's well-being from the jump. Like right from in the 18th century, it's very clear that that is happening.
So many ways in history, a stories told of African Americans and the African American community not having a voice. And part of what this is saying, no, there was a voice. There was a voice. Another question, I was wondering if you had any thoughts on racism perpetuating in modern medical education. Are there efforts in education of new generations of physicians that you think are particularly effective, or gaps that you are aware of? Are there efforts in terms of using this kind of knowledge that you're bringing forward to address how people are being taught today?
So again, I love this question. I know that many medical schools are, or I know at least are getting rid of or sort of downplaying EGFR. It's like we don't need to use this as much as we were. I would say that, a lot of that I think stems from the kinds of work that historians do and other scholars. So I know that Dorothy Roberts has written about the problem of the EGFR, that she has been very clear about sort of what race is and the purposes that race serves, is sort of something that is a dangerous invention. Like for me, I think that kind of work is being sort of translated into ways in which new generations of medical students are being trained. So I think to the point of EGFR, but I would also say that some of the work, for example, that Lundy Braun has done on the spirometer, so thinking about race correction and lung function, that is now, I have found to be a topic that when I go and talk to medical students, medical residents, and like sort of giving these kinds of talks, now I feel like there are more audience members that are able to say, I've heard about this in the spirometer, or there is, people are telling me about Lundy Braun's book, which is great. Her book is fantastic. And I'm so happy to see that, here we have, again, working in the humanities, doing this kind of historical work, that it is filtering through in terms of the generations, at least that I have interacted with, of residents and med students who know about race correction, who know that is a problem. Now, what other ways can this sort of be, translated? I am less sure of how that might work in terms of decisions around VBAC and sort of cesarean outcomes for African-American women and Latinx women, which we do know there's still sort of this racial disparity. How is that being tackled in medical schools? I couldn't speak to
Right.
that from personal knowledge, but hopefully that change is on its way.
You know, we've had Linda Brunt speak here and in this community also. But part of what this raises for me, and this is where I have hope, and I always walk with hope, but where I have hope is that our students are asking questions and they're challenging assumptions and saying what assumption based on what and where did you get the data, and we need fresh eyes, fresh voices, fresh lenses, challenging us on how we've done things, not just about race, but more broadly, um, as we move forward. And part of this for me is about representation, but a part of this is also about individuals looking at the evidence and saying, is this evidence that we can trust? Is this evidence we should believe? And how do we re-examine? And our students are doing that. Very much encouraged by that. Also very much encouraged by the clear linkages, such as Harvard's and the Center for the History of Medicine, and the ways in which the historians are bringing to light evidence and understandings for what we're doing today. And as opposed to this us being siloed, the work is actually coming together.
Right.
And appreciate you for the work that you have done, this enlightenment. You don't know how much I'd like to get to that New York Public Library and see the kind of things that you're looking at.
It's great. It's there's so much. There's so many records.
And for those in medicine who are looking at this, or in history and other places, but I also think about the younger people who are coming through of here's a field that you could go into. Here's where, to me, we need more individuals who are doing this kind of work, who can join you in this kind of research.
Oh, we welcome that. I actually love the idea of working more with clinicians and kind of I dream of the day of sort of saying, okay, it would be great to come to the archives and have, you know, clinicians come to the archives and think with me and think about some of this work. And then in the same way to have historians kind of think about, you know, how clinicians are making their decisions or sort of their challenges, because I think that you're absolutely right that having this sort of cross-pollination like is essential. And I really appreciate, and I'm also glad to hear that students are asking questions and challenging. I think that that's kind of the only way we're going to do this. We're going to move forward and being receptive to these kinds of questions. And yeah, so I would be delighted to hear of more students having interest in this, MD, PhDs, folks who are just interested in kind of doing these kinds of deep dives or even having these kinds of conversations.
Absolutely. We need them. We actually need them to carry this work forward. I thank you for a wonderful presentation. I thank you for, in some ways, leaving me with more questions than answers, which is where we should be, I think. And look forward to your latest publication, the work that you continue to do. Thank you all for joining us for today's program. It has been recorded, and we will be able to see that recording. I encourage you to look at the books that you have published to date, and to learn from them, to hear more, to learn more. You are able to share some of what you found, but there's so much more for us to understand. At the end, there is going to be a brief poll to help us understand how we can do better with these sessions. But Dr. Hogarth, thank you so very, very much for the work that you do, the contributions that you're making, and for pushing us forward in this space. Thank you for joining us today.
Thank you so much, Dr. Reed. Thank you very much.
Thank you. Bye-bye.